do these math problems. Okay, so this is very like what the questions are going to be on the exam. So this is a patient that's getting 3.375 grams of Zosyn diluted into 50 milliliters of saline, and it's got to go over 4 hours. And that's the standard way Zosyn is given. It's given really slowly. So what rate will the medication infuse in milliliters an hour? And where people make the mistake always is they include the 3.375 grams of Zosyn. Think of that as like a powder. The pharmacist mixes this one, but that powder is diluted and mixed into the 50 milliliters. Yes, that's what happens when you do that. So the solution doesn't, that volume doesn't change. That is what that powder has been diluted into. So the grams in this question is not important. It's the 50 milliliters that I have to give over 4 hours. So then the question is, how am I going to do that? And then it's actually more simple math problem. I have to give 50 milliliters over 4 hours because this is a milliliters per hour. And so the answer is 12.5 milliliters an hour. So be sure, remind yourself when you're taking the exam that that's just telling you the dose of the drug, because that's how it'll be written on the MAR too, that you're giving this dose of Zosyn, and this is just how it is being presented to you. And that's how all of these are. The next one, the patient is getting a gram of vancomycin diluted into 250 milliliters of D5W. Again, we're only worried that we got a bag that looks like fluid. There's medicine in it. We can't tell. It was mixed beforehand. We have to infuse this medication over 90 minutes. What is the rate round to the nearest whole number? So I have to give 250 milliliters over 90 minutes. So this is milliliters over minutes. I need to get to milliliters an hour. So I have to convert my minutes to hours. And then it's 250 times 60 divided by 90, which would give you 166 point, I can't remember. Did I not round that right? Possible.
It was like 1.666666 like that. So I rounded
to the nearest 7.
I rounded up to 7.
Yes, it should be 167. I would have gotten that wrong on my own test. So that's correct. And then, so if you put 167, that is the right answer. And then the next one, the patient is to receive 500 milligrams of Cipro diluted in 100 milliliters of normal saline. I have to give this 100 milliliters over an hour. So that was an easy one. This, I feel like, would be one that you guys would stare at and be like, that can't be that easy. But it is possible that it could be that easy. So don't do that. You know how you guys are.
What threw me off is that you didn't put a milliliter/hour in there.
Oh, I didn't.
So I said maybe it's a 1-to-1 then. Maybe it's 100 milliliters for every 1 hour.
Oh, well, it would still be 100 milliliters an hour then.
Yeah, that's why I put 100.
Okay, you're good. It still worked. So the answers were 12.5, 167, and 100. Anyone have any questions on those? Because that's very typical of what you're going to see on the exam.
So
yeah,
that last, I'm sorry.
Go ahead, sorry.
That last question, where it did not have the rate of like how over, the timing of rate, would we automatic? Is that just an error on your end, or could this be on a test and would that automatically be an hour? Like, would we just assume that it's being ran over an hour?
Right. Usually I put milliliters an hour. The reason that it could be assumed is that that's what the pumps are usually set as milliliters an hour, but I will put it on there so you won't be confused at all.
Okay. I just didn't know if an hour was like a standard time. should just
So
know
it
that.
actually is, but I don't want anything to throw anybody off.
Okay.
But that's usually how the pumps are run, where you run it when you're setting it up, you put it in as milliliters an hour. But I'll have it on the test clear. I just do that in there during a break. Um, Anyone else have any questions about those? Oh yeah, I think there was one that I was reading and then I put 100. Oftentimes you just have to put the number down. You don't have to put the units of measurement. That's how ATI is too. Because then it gets all tricky because you never know how the computer's going to take it. Maybe it's going to want a space. Maybe it's not going to want a space. Like, so just the number. Okay. So now we're moving on to our next topic, which is chemotherapy. So treatment for cancer. And first we have to sort of understand what cancer is. Normally, the cell cycle or the cellular division is highly, highly regulated. We only make a copy of a cell in order to replace a cell that's worn out. We don't make more cells that are needed. There are lots of mechanisms that the body has in place to stop the overgrowth of cells, kind of based on how they're positioned. They're supposed to stay within their borders and they're not supposed to crowd out the cells that are next to them. So, what happens with cancer is that those normal things, those normal mechanisms that the body has in place that stop cells from dividing abnormally are gone. It's because of a mutation in the genetics of that particular cancer cell that suddenly the rules that usually apply to cellular division no longer apply. And so cancers will start to grow uncontrolled. The cells grow uncontrolled. They may not look very much like the place they first started. You know, a person has breast cancer, the cells will start dividing abnormally and they might not look that much like breast cells anymore. Eventually, those cells that are creating a tumor will create their own blood supply. They have their own vessel growth factors in order to support themselves, and they will secrete enzymes in order to break through, the linings of vessels or the linings of other organs so they can get in and grow someplace else. So obviously that's bad. These cells are rapidly dividing, they create their own blood supply, and they have the ability, if close enough, to travel through the bloodstream or through lymph nodes, and that means that they have the ability to set up shop someplace else, which is metastasis. You know, the cancer started in the breast, and in this picture, the cancer has detached into the bloodstream and then went into the lungs and the liver and the bone, which is frequent places where breast cancer can travel. So because cancer is abnormally dividing and rapidly dividing cells, much of the targets of chemotherapy is trying to target rapidly dividing cells, especially the early chemotherapy agents. Some of the newer chemotherapy agents that have just come, are very target specific, trying to aim at cancer itself and not at other cells, because it's not just cancer cells that can grow rapidly. It's also other cells in our body that are used for maintenance that grow rapidly. The mucus cells in our GI tract have a high turnover rate because they're often damaged, just normal day to day use with eating and passing stool and digestion. The cells of our hair follicles are high. They go through a lot of division. The cells in our bone marrow are divide very quickly. The ones that we have been talking about that create the red blood cells, white blood cells, and platelets, and our cells that support fertility or reproduction, especially sperm. So those cells can be destroyed or harmed even though what we were trying to do was harm the cancer. So chemotherapy medications can be taken by mouth or IV, and there are many types, many categories of chemotherapy drugs, and the oncologist will pick those based on the characteristics of the person's cancer and where it's located and what tends to work best for certain types of cancers. But all of these drugs are very hard on the patient to varying degrees, and they have their own rules when you're giving them. Especially IV chemotherapy has to be handled in a particular way because it is toxic. So it could be toxic to you, the person that's getting the medication ready. It can be toxic to the patient if it gets to places it's not supposed to go. And it can be toxic to the environment if it spills. So everything has to be handled carefully. If chemotherapy spills, that's considered a toxic chemical spill, and there'll be like a hospital policy about how to clean up that area and close it off. It wouldn't be something you would just go grab a towel for. If you are the person that is handling the IV chemotherapy, you have to wear special gloves so that if perchance some of the liquid came out, that your skin would be protected. They're like a different type of blue glove. There's generally a special jacket that's also worn, and there's a special disposing container for the leftover stuff, like when the bag is done infusing, that you would have to dispose of the tubing and the bag. This medication, we want it to get to where the cancer is, but we don't want it to get into the skin. So if the patient has an IV line, we have to be very careful because all chemotherapy is what is called a vesicant. So it has the possibility of burning or killing the skin. So if that IV is not in the vein and you start giving the medication and that chemotherapy gets into the skin around the vein, instead of it just getting swollen, you'll actually have a huge tissue injury that might require surgery for repair or amputation. And that is why, and this is usually on the exam, is that when someone is getting chemotherapy, it is desired that they have a central line so that it's in a larger vessel and there's no to minimal chance of there being any issue with burning or damaging the patient's skin. So a central venous catheter, which is what CVC means, would be a temporary way to do it, but the best choices are a PICC line, which are long lines that actually end towards the right side of the heart, or some kind of implantable port like a Metaport or Passport. And those are really nice because there's actually skin, normal patient tissue over the port, so they're less likely to get infected. If the person has to start chemotherapy and they, for whatever reason, don't want a central line, or we want to start it before the central line is available, then you should pick a large gauge IV. So that means the number is lower, but the actual diameter of the tube is high. So you would pick like an 18 gauge or 16 gauge IV, and you would want it to be away from joints where there's bending and there's a higher potential that the IV could come out and damage the person's skin. Just like when we talked about antibiotics having frequent side and adverse effects, all chemotherapy agents, some more than others, have the potential to cause these common types of effects. Hair loss. Not all chemotherapy agents cause hair loss, especially some of the newer ones or the ones that are pills, but it's still possible, and many of them do cause hair loss. Mouth sores, which is what stomatitis is. It means that there's inflammation inside the mouth, so it makes it difficult for people to eat. It can be painful and keep hydrated. Some degree of GI upset. It could include diarrhea, which isn't on there, but that's also part of it, because those mucus cells that line the esophagus, stomach, small intestine, large intestine are also hot cells with high turnover. So it's possible that we could disrupt that turnover. Nausea and vomiting is very, very common for many chemotherapy agents, although it does vary, or possibly diarrhea. Hyperuricemia, that was one of the reasons when we talked about allopurinol that people, mucositis is a common side effect. It is, people sometimes use mucositis in the same way as they use stomatitis. It's just inflammation of mucus, and there's mucus inside your mouth, so that's inflammation of mucus, and you can have inflammation of the mucus in the bowel. And so that's basically what that means, is that areas where mucosa are, or where mucus tissue is, becomes inflamed. Hyperuricemia, that's, we talked about that earlier when we were thinking about musculoskeletal conditions. Gout is the condition where people get pain in joints from extra uric acid. A lot of chemotherapy agents actually change the way the body handles uric acid, and uric acid can be elevated. So if a person is taking allopurinol in this setting, it's not, I mean, it will help prevent gout and kidney stones, but it's not that they have gout. They might not have to take it once they probably won't have to take it once the once the chemotherapy is done. It's just that during the chemotherapy, that uric acid level will be low. We have to worry about bone marrow suppression. This is one of our biggest worries when somebody is getting chemotherapy, that they will have a decrease in their white blood cell count, red blood cell count, or platelets. Sometimes that means they have to wait to get their next dose of chemotherapy, which is bad. You don't want to give cancer a chance to start taking hold again. If their white count becomes too low and they become very immunosuppressed, they're at risk for infections, which means you would also have to hold chemotherapy and they'll get very sick. That's not good. Anemia, they might require blood transfusions. Platelets, they might require platelet transfusions. So that's watched very closely. And oftentimes, if young people have cancer, they often will do things to bank egg and sperm in case they want to maintain fertility. It doesn't mean that they for sure won't be able to have children, but because that risk exists, sometimes people do bank that stuff. And then it can happen that you're pregnant and have cancer, which is unfortunate, but most chemotherapy agents are at least pregnancy category D, because obviously the developing embryo and fetus is full of cells that are rapidly dividing and changing and becoming specialized to create this baby. So taking chemotherapy could very much damage the developing fetus. And most of the time, what would be good is that you weren't pregnant. Starting chemotherapy, you would be on birth control to be sure that you didn't become pregnant during chemotherapy. So we're going to talk about, there's a lot of classes there, but there's only one drug per class, and one of the medications we've already talked about a bunch of times. But these medications are trying to stop cell division and damage DNA, essentially, except for the hormonal agents. That's a whole different type of medication. These ones in the box there are medications that are trying to interrupt cellular division for rapidly dividing cells. So here we are, methotrexate again. This is the highest dose of methotrexate. We're disrupting DNA synthesis if we block folic acid. So this is high dose methotrexate, much higher than what we gave for prevention of organ rejection, way higher than what we gave for rheumatoid arthritis. So this is our biggest worry. We can have profound bone marrow suppression. And if that occurs, the antidote to too much methotrexate is leucovorin. I'm not sure if you can hear that, but there's a cat that's mad that no one's paying attention to. So if you hear that, that's just my cat. Okay, and then pulmonary fibrosis is the other potential worry, which is asthma-like symptoms, cough. The next type of agent, the next family of medications that we could use for chemotherapy are what are called alkylating agents. And what they do is they damage DNA crosslinks. So that means if the cell's DNA is damaged, then the cell should hopefully be killed as a defective cell. So this is a drug that can be taken by mouth, and it's taken with food. Sorry, without food is what that says. There is a possibility for some electrolyte abnormalities, hyperkalemia or hyponatremia. One of the important things about this agent is something called hemorrhagic cystitis. That means that as this medication circulates through the body and is filtered by the kidneys, it can cause inflammation inside the bladder, so much so that the bladder could bleed. So if the patient starts to urinate blood or sees blood and clots in their urine, then they need to be seen. They need to come to the hospital. They'll probably need like special flushing of the bladder to prevent clots from forming, making it harder to urinate, and they might, need to pick a different chemotherapy agent. So remember, this is cyclophosphamide, not to be confused with cyclosporin, which is unfortunate. There's two medications with such close names. It's cyclophosphamide. It's an oral chemotherapy agent that stops rapidly dividing cells. We still have to worry about all those things we worried about. The patient's probably going to be at increased risk of infection. They may lose their hair. It might make them sick to their stomach. All those things that we talked about, but extra is this hemorrhagic cystitis that we have to be sure the patient is aware of and they know what to do if it develops. The next family, so we had our anti-metabolites, which is that methotrexate that we always talk about, alkylating agents, cyclophosphamide. Now we have platinum compounds, and that is cisplatin. This is platinum, just like it sounds. It's a metal that causes abnormal crosslinks in DNA, so again, damaging cellular DNA so the cell dies. This is an IV only medication. We have to worry about the things we always have to worry about with this medication: hair loss, nausea, vomiting, sores in the mouth, potential diarrhea. For this one, the GI symptoms can be quite severe and happen very fast, even while the medication is infused or right after the infusion. So people usually are pre-treated when they get this, to try to help decrease that sensation with something like Zofran, or medication that decreases nausea. There's a high risk of allergy to this medication, and so epinephrine has to be on standby just in case, so that the patient, so that the lungs open up as fast as we can get them to. Neuropathy, which means paresthesia to the hands and feet, ototoxicity, which is damage to the ears, and nephrotoxicity. So this is a very, very toxic chemotherapy and is reserved for things like ovarian cancer, some metastatic breast cancers. So it's not without a lot of issues. Right here you'll see, and this will be very important when we talk about growth factors, is something called the nadir. And nadir means lowest point. Like the apex is the highest point, the nadir is the lowest point. And what this is saying is 18 to 23 days after the patient's infusion of cisplatin, they will experience their lowest levels of cells that are made by the bone marrow. So if someone is on a platinum or a cisplatin chemotherapy regimen, they might get cisplatin infusion every month or every 2 months. And so they would make an appointment and they'd go to the chemotherapy infusion clinic, and that specially trained nurse will give them their chemotherapy infusion, and then the clock starts. So you get your medication, say this is the days, here's day 1. I got my medicine. And at that point, my blood count should be normal. Once we start to get to, day 10, these counts are going to start to decrease as time goes on, all the way till maybe we get to day 20, and it'll be at its lowest point before it starts to pick up again. This is the point where all along the way we might have to start worrying about the person, but this is the point where the most worried about this person in terms of especially risk of infection. Because the last thing we want to do is have a patient who's getting chemotherapy get a really bad infection, because then we can't give them their chemotherapy. They have to wait, which means the cancer has the chance to grow while we're trying to treat it. And also, of course, the patient is very sick, but we gave the chemotherapy to get rid of the cancer, and now if we've made it so that we can't give the chemotherapy, then we won't be able to cure the cancer, get rid of the cancer. So we need to protect the person. So why do you have to know the nadir? Well, one, it's because clearly as you get around this time, the patient needs to be protected. They should be at home. They should limit visitors. They shouldn't be going out a lot. They certainly shouldn't be going to places outside of their home that is enclosed. They have to be washing hands. Everybody who's near them needs to wash hands often. No fresh fruits or vegetables. No undercooked meat at all. Sometimes no flowers, because at this point they could be something called neutropenic. Some people's counts get so low that they have barely any white cells at all. They might have just like 1 or 2 white cells, and they won't be able to fight anything. To counteract that, and that will be the last group of slides, what the person can do or could be prescribed is a growth factor. You could get a medication before the lowest point, which is what we'll talk about with the growth factors, like filgrastim, which is Neupogen, to try to build up the counts so that the patient never reaches the nadir. But so the reason that's important, especially the white count that we're worried about, is because of their risk of infection and the need to protect them. And then it also offers the opportunity to give the patient a growth factor, which we would want to give, if we could, before they experience the lowest point. Okay, any questions about that? Because understanding that is important. No, Lillian's good. That's good. You're a good barometer, like a kind of a good temperature for the class. Okay, so our next class of types of chemotherapy agents are what are called anti-tumor antibiotics. There's a whole class called Anthracycline that can be used in order to damage and prevent repair of cells. Our prototype is doxorubicin. This is another IV medication. This one has a nadir that's earlier than cisplatin. We said it was 18 to 23 days. So in my picture, I said about 20 days. The nadir for doxorubicin is 10 days. So that kind of changes when we have the protection time of the patient, or when we might give the growth factor to prevent them from experiencing a bad infection. This is a problem with doxorubicin because even years later, the patient can develop heart failure, or the cardiac toxicity that we're talking about is heart failure. So the patient could have had breast cancer and was treated with doxorubicin when they were in their 40s, And in their 60s, they developed heart failure, and they never had any other risk for heart failure besides the fact that they had this, chemotherapy agent. So we have to watch their heart forever once they get it. Liver toxicity, and this red urine is different from the cyclophosphamide that's causing hemorrhagic cystitis, where the patient is actually bleeding from their bladder. This is for 1 to 2 days after the medication is infused, the patient's urine and tears are red. So the one way to really tell the difference between urinating something that's red and urinating blood is that it is much darker, the blood colored urine, and having hemorrhagic cystitis is incredibly painful. Cystitis means inflammation. So the person who has hemorrhagic cystitis is in pain. The person that has red urine while freaked out is not in pain, and they don't, it's not going to look like blood. It's going to look like clear red, almost like Kool-Aid. But definitely something you want to tell people, because that might freak them out. So I always think like, oh, doxorubicin makes urine and tears like rubies, if that helps you remember. I don't know, sometimes you have to think of goofy things to help remember stuff. And then our last class of chemotherapy medications before we talk about hormone medicines are the anti-mitotics. So mitosis means division of cells, of somatic cells, regular body cells. If it's anti-mitosis, then it's stopping division of cells. So our taxane that we're talking about that is an anti-mitotic is paclitaxel. So this paclitaxel is an IV medication only. It needs special filter and special tubing. It also has an issue with allergy, sort of like the anthracycline. The cisplatin that had the high allergy risk. So people are usually pre-treated with antihistamine and steroids. Our nadir is at 11 days, so it's similar to doxorubicin. The patient, when they're at the infusion clinic, would have to be on a monitor so we can be sure their heart rate doesn't get too slow. The biggest reason why people start to not tolerate the taxanes over a long period of time or might have issues continuing with paclitaxel is the horrible neuropathy. So the peripheral neuropathy in their hands and feet can start to be painful, but especially in the hands, the patient might also lose fine motor movement. They won't be able to actually take care of themselves. They won't be able to put their clothes on or tie their shoes or, manage stuff because they won't be able to move their hands correctly. And then the last medications in this group are a little bit different. So far we've talked about cancer treatment that is aimed at stopping rapid cell division because we know cancer cells rapidly divide. This next set of drugs, 2 drugs, are hormone receptor blockers because certain cancers are sensitive to hormones, and when those hormones are present, it'll make the cancer cell proliferate. It'll make the cancer cell divide. So if we block receptors on the cancer cell that are pro-cellular division, then we can slow the growth of that cancer. And the particular cancers where this is more of an issue are things like prostate cancer that often are stimulated to grow in the presence of androgen or testosterone, and breast cancer, which can be stimulated to grow in the presence of estrogen. So people will sometimes be on these medications not necessarily as the primary treatment for their cancer. This might be after they've gotten through their chemotherapy, they'll stay on these drugs for several years afterwards. So the first one we're going to talk about is androgen receptor blockers, or a medication that'll block receptors on cells that for testosterone, thinking that if we block that receptor, if there is a cancer cell left behind, we've taken away its induction to grow. So prostate cells or prostate cancer is the abnormal growth of malignant prostate cancer cells, and androgen receptors on cancer cells can make them grow faster or make them start to grow like a cancer. So we can block those receptors to slow the growth and decrease pain. So for testosterone, or sorry, for you guys, it's a long day to talk for this long. For prostate cancer, depending on how old the person is or what their treatment decisions are, or maybe they're taking this after active treatment, you can just use an androgen receptor blocker for an older man whose cancer is growing very slowly, or you can use it after treatment is finished. So our medication is flutamide, which is an androgen receptor blocker. So if I'm a leftover prostate cancer cell that would be induced to grow if testosterone was around, if I block those receptors, then it won't grow. This is a pill that's taken 3 times a day. It is blocking testosterone in other places because it's not selective to just prostate cancer cells. It's blocking androgen receptors in the body. So the man will experience female secondary sex characteristics like gynecomastia, which is breast growth, hot flashes, which occurs in menopausal women. They might have trouble with erection and decreased libido because the testosterone is blocked throughout the body. And then the last medication to talk about is a specific hormone receptor medication that's used in breast cancer. So obviously breast cancer is abnormal growth of malignant breast cancer cells, which usually starts, although it can start in the lobules, this part of the breast, usually starts in the breast duct, and is responsive. Many cancers are responsive to estrogen. The estrogen will increase their growth. So we can try to selectively block estrogen receptors. There are estrogen receptors all over the body too, not just in the breast. They're in the brain. They control temperature regulation. They're in the bone. They help control bone balance to prevent osteoporosis. They're in the uterus and are involved in the growth of the endometrial layer during normal periods. And estrogen has a role in clot prevention. So it protects against clots. That's why when women get through menopause, their MI risk increases. So tamoxifen is an estrogen receptor modulator. That means it activates some estrogen receptors and blocks other estrogen receptors. So when we talked about the androgen receptor medication, that medication blocked all androgen receptors. It didn't just block some of them. This estrogen receptor medication blocks only some of those receptors. It blocks the clotting ones. It doesn't do that. It blocks the breast ones, which we wanted, but also the brain ones. But it activates estrogen in the bone and activates estrogen in the uterus. So we end up decreasing our risk of cancer continuing to grow, which is what we wanted, but we could end up with hot flashes. We could increase our risk of uterine cancer if we're allowing endometrial tissue to grow. We could increase our risk of blood clots, and then we have to watch the patient's eyes. What was the other medication we used that we had to watch people's eyes for retinopathy, where they had to see the eye doctor? which medications did we talk about that caused, which other medication did we talk about that caused retinopathy? Which means where the recommendation was that they saw the eye doctor frequently. No. Yes, hydroxychloroquine. So we talked about a form of that medication. Yes. We talked about a form of that medication last class because chloroquine is the same as hydroxychloroquine. It's marketed for treatment of malaria, but usually people are not on it as long, so they don't need the eye tests regularly, but we do need to have them let us know if they're experiencing vision changes. What are some of the medications that cause cataracts? It might be what you're thinking of, Natalie, but it's not allopurinol. It begins with an A. Or Natalie, I don't know what I just said. There were two, and one we just talked about. Yep, prednisone is one of them. It's amiodarone. Was the other one that caused cataracts. So kind of keep throwing those questions at yourself to challenge yourself to be sure to see what you remember. Okay, it's 1:50. We've definitely earned a break. The other thing we're going to do is take a refresher quiz looking at some of the side effects or effects of some of the medications we've talked about, which I'm going to open up. It's a matching thing. So you have 10 minutes for a break and 10 minutes to try this matching thing. So we will meet back at 10 after 2 to go over those answers and do our last group of slides. So 10 after 2.